Hi guys, this is Jody and we're going to talk about drugs for the respiratory system. So you want to look at the respiratory module in ATI Pharm Made Easy. We're going to talk about drugs for the upper and lower respiratory disorders. I am sure you're all very well informed of upper respiratory disorders like nasal congestion that can come from allergies. It can be sinus infections, common cold, flu. So there's not a whole lot we can do for these unless, it becomes bacterial like a sinus infection you may need an antibiotic for. Generally, what we're doing is treating symptoms. Do know that you can have a common cold, you can have the flu that then progresses to a lower respiratory disorder. So you definitely want to treat the upper respiratories to prevent a lower respiratory disorder, which then affects the bronchioles. You have inflammation like bronchitis, I'm sure you guys have heard of. You can see pneumonia. This also includes asthma and COPD, which is chronic obstructive pulmonary disorder. Which usually COPD is an umbrella term where you have chronic bronchitis or emphysema. Atelectasis, so we're not bringing airway all the way down to the bases of the lungs, tuberculosis, pulmonary edema, and then acute respiratory failure are all disorders of the lower respiratory system, which is definitely more severe. So we're going to jump into the lower respiratory first, and the first drug we're going to talk about is a beta adrenergic agonist. So we are stimulating those beta receptors, which are both in the heart and in the lungs. And so we can see impacts there. Okay. So what we can cause is what we want to happen is bronchodilation. But we know that when we stimulate those beta receptors in the heart, we can also cause an increased heart rate or tachycardia. So we do have to watch for those effects. Generally not too much of an issue if a patient has a very stable resting heart rate, but you do want to watch for that tachycardia and if they're feeling any chest pain or palpitations when giving albuterol. This is if you're giving multiple inhalers, like you may be giving albuterol and Atrovent, and they may have another prescribed inhaler because there's a gazillion of them out there. You want them to use this one first if they're taking it on a regular basis because it does open up the airway and they will be able to inhale and receive more of those other inhalers if they use the bronchodilator first. This is also a rescue inhaler. So if you have somebody who has like asthma, I know I've been prescribed this when I've had pretty severe bronchitis. You can use it when you're symptomatic to open up the airway. The more you use it, the more at risk you are for tachycardia, so you do want to be mindful of that. You want to teach them to avoid things that are going to stimulate that heart rate. So caffeine is one. So if they're using this, you want to tell them to avoid some caffeine. Again, report the chest pain and palpitations. If they are diabetic, this drug is known to increase sugars a bit, so we might need to do more frequent monitoring of their blood sugars. Anticholinergics. So ipratropium, which is also known as Atrovent, is a big drug that is prescribed. Anticholinergics are those drying drugs, okay? And so what we're doing is reducing secretions. Okay, so with the albuterol, we're opening up the airways. With this, we're going to reduce the secretions in the airways, and so we dry them out pretty significantly. And so we can tell them to take sips of water, suck on some hard candy. That will help manage that dry mouth. I will tell you with essentially any inhaler, you should be instructing your patient to rinse their mouth after use because if it's a steroid inhaler, we have that steroid sitting on the tongue. It's going to put them at risk for thrush. Any medication can sit kind of back on the tongue. So this one in particular dries them out, but always good practice to tell your patients to rinse their mouth after inhaler use. And also, to clean the mouthpieces of their inhaler. Another drug that you might see for long-term, so again, I will say this for long-term treatment of chronic asthma is theophylline. This one we have to be very cautious with because there are some toxic effects of this drug, and it is impacted. So you may have patients on cimetidine for reflux disease, and this does increase the risk for toxicity. So we do want to look to see if there's any medication reactions or interactions, I should say. There's also risk for toxicity with this drug. So this is one where we would need to monitor blood work. pretty routinely just to check those levels, because if they do become toxic on the theophylline, it puts them at risk for seizures and dysrhythmias. And we do with this one as well want to make sure that they're avoiding caffeine. Then we're going to talk about glucocorticoids, and I don't know about you guys, but I can tell you when I've had pretty significant respiratory disorders that progress into like a bronchitis, I've gone in and what they'll usually prescribe for me is they'll give me an albuterol inhaler. They may give me a Z-Pak, which is an antibiotic to just try and kick any infection that's in there, if it's a bacterial infection. And then they will give me a low dose, very short-term course of prednisone. Okay, that's the glucocorticoid. Glucocorticoids are going to be used for many different disorders if there is inflammation that we need to decrease pretty quickly. So I don't know if any of you guys have been on a glucocorticoid, but they have some pretty awful side effects, but they are like miracle drugs and they work very quickly on inflammation. So it is an anti-inflammatory. If they are using the inhaler, using a spacer is a good idea, especially if you're using for kiddos, because they have a hard time when they're hitting that inhaler of kind of doing that deep breath and getting that, how to actually use an inhaler. And if you use a spacer, when you press the inhaler, that medication kind of sits back in that spacer so you can breathe it in nice and slow. You want to, with glucocorticoids, no matter what you're using them for, you want to avoid NSAIDs. So these are your non-steroidal anti-inflammatory drugs. This will increase the risk for GI bleeding if they're taking them with their glucocorticoid. So this would be your aspirin or ibuprofen. Because glucocorticoids do suppress the immune system as well, we have to watch for signs and symptoms of infection and also instruct to prevent infection. So we definitely want them to be vaccinated, but this says no live vaccines. You want to assess for infection symptoms and then, avoiding large crowds, hand washing, making sure, especially this time of year, we're talking about flu, pneumonia vaccines, COVID vaccines, all that good stuff. Diabetics have to be very cautious because these drugs usually do bump up the sugar pretty significantly. So they may need an increased dose of their diabetic drugs while they are on the glucocorticoids. So we would monitor more closely and watch for that in case we need any dose adjustments. Then we're going to talk about mast cell stabilizers. So this one talks about cromolyn. This one also suppresses inflammation. You want to assess for an allergic reaction because we have had people have allergic reactions to the cromolyn, and we would treat any anaphylactic reaction with epinephrine. And you would administer this nebulizer or inhaler 4 times daily on a very set schedule. Okay. And then montelukast is a drug that you will often see prescribed. This drug is also known as Singulair, if you've heard of that. It can be prescribed for exercise-induced asthma. So if somebody knows that they have issues and they're playing sports, this may be something that they are prescribed. This one, I think they say take in the evening to match the peak drug levels with symptom onset. Periodic testing for liver damage. You can see some suicidal ideation with that, so you would want to monitor for that. Monitor for any behavior changes, and also when we talk about anything that can impact the liver, you have to know to watch for signs and symptoms of liver disease. So this could be decreased appetite, nausea, abdominal tenderness. The later signs of it would be jaundice, so yellowing of the skin, yellowing of the eyes. So now we're going to jump to upper respiratory disorders, which are a lot more common, definitely treated more in an outpatient setting. And diphenhydramine is your Benadryl. This is a very common drug that we give. It's very drying if you've ever taken it. It's very drying. So with those drying drugs, they can cause constipation, urinary hesitancy, and This drug in particular causes very significant sedation. So you may see that it's given to help a patient sleep. I think it is the actual ingredient in Tylenol PM. So it's Tylenol and diphenhydramine to help individuals sleep. So very often used for allergy type symptoms, but it will make people drowsy. I can tell you my dad has an allergic reaction to bee stings. So if and when he gets stung, his first course of action is to take some Benadryl. Drug therapy, another one, non-sedating antihistamines. So this is cetirizine, but it may cause some drowsiness and fatigue. It should not to the level of like a diphenhydramine. You don't want to take it with any other over-the-counter antihistamines. It does have some of those drying effects, which are the anticholinergic effects. And you do not want to take it with theophylline or any, you don't want to take it with CNS depressants either, so that would include alcohol. Phenylphrin, I can never say this one. This one is often taken to reduce nasal congestion from the common cold. You guys may be more familiar with Sudafed is a brand name of this drug. Very often used to treat the congestion that comes along with the common cold. It may increase heart rate and blood pressure, so you would want to use this very cautiously in people who have cardiac disorders. And you would want to do more close monitoring if they do have a history of, say, hypertension, to look for the effects of that. Antitussives. So you may see the opioid drug codeine. Now with opioids, which we will talk about later in the semester, so we think about opioid drugs are often prescribed for pain. Okay, they have opioid effects, which can cause respiratory depression. Other effects are constipation. There is potential for abuse of this medications, as they are with any opioids like fentanyl. You want to keep naloxone on hand if somebody is taking any kind of opioid drug. And it's contraindicated for those if they have a history of substance abuse, because again, this does have the potential for abuse. So this is codeine. It can be used for patients who have like significant cough. And so you sometimes will see codeine in a prescribed medication for patients. So this is not something they can go in and buy over the counter. It would have to be prescribed. A non-opioid antitussive is dextromethorphan. So this is one that is usually in cold medications. So the biggest thing too is when patients are taking combo meds and then they go out and buy the med by itself, you just want to make sure that they're not taking too much of the medication. So they have to just be very mindful if they're buying an over-the-counter cold medication, that they're not in addition taking that medication on its own. So a good example of this would be like Tylenol. If somebody's taking a cold medicine that has like a Tylenol in it, they don't want to in addition take additional Tylenol, because then they would be overdosing on Tylenol. So we just want to look at what is in your medications, but dextromethorphan is usually the cough suppressant that you will find in this. So again, what we're doing with an antitussive with either one of these medications is decreasing that that reflex to cough. So you will see some patients who have just a difficulty sleeping, or it's just irritating because they can't stop coughing. I will say that it is a good thing to cough, right, when we have like a lot of mucus, and we want to bring that up and out of the lungs. So I don't want you to think that we just normally throw an antitussive at a patient, but this would be for somebody who has like this dry, nagging cough that continues and continues, and it may be keeping them up at night and that type of thing. So we give them an antitussive. Now you will see combo meds out there that will have like a medication that will thin secretions and make it easier for the patient to cough them up. And then you might say, well, why are we then giving them an antitussive on top of it? Well, it's really kind of numbing that reflex to cough, but a person, if they have those secretions in there, should still be able to bring those up. So expectorants, those would be the next one. So those are the ones that thin the mucus to help patients bring it up. If somebody is on an expectorant, you should be, first thing, telling them to drink plenty of fluids. So if you've ever gone into the doctor with cold symptoms, flu symptoms, they should be telling you make sure you're drinking a lot of fluids. This helps thin your secretions so that we know if mucus gets really thick, it's more prone to block up those airways and make it more difficult for you to breathe. So we want to thin those secretions. It makes it easier for you to cough them up and get them out of your lungs. So that's what we're doing. And I have this gentleman over here, this little boy, drinking a big thing of water because that is a natural expectorant. A natural thing that thins our secretions is drinking plenty of fluids. Watch again for over-the-counter medications that contain the same drug. So this is often in a lot of your cold medicines. So you don't want to take it in a combo drug and then on its own because you could be putting yourself at risk for taking too much overdosing on this medication. Avoid driving as it can cause some drowsiness. And then lastly, we'll talk about mucolytics. Acetylcysteine is one that you may give in the hospital setting. This is really, it smells like egg when you have to give it. It's Mucomist, and you can give this inhaler, and it's very stinky. It has a very stinky odor to it, but it actually decreases the stickiness of the secretion. So if you have somebody with a lot of secretions coming up. I used to give this a lot to patients who had new trachs because they would have all this mucus and that mucus would be thick and sticky. So this actually kind of breaks that up a little bit and decreases that stickiness, that viscosity, that thickness of the secretions. You may have some bronchospasms that occur with this, so you should always be monitoring their respiratory status, having some suction equipment at the bedside to help with those secretions. And then when you are giving any kind of nebulizer, whether it be Atrovent, albuterol, Mucomist, or acetylcysteine, I should say, you want to make sure that you're cleaning their equipment. It drives me just crazy in the hospital when I see this stuff kind of just hanging over and they keep putting it on the patient's face. We should be cleaning that equipment, especially if they're coming in and they have an infection. You don't want to put that back on their face. So make sure that we're cleaning equipment. At home, I would usually tell patients if they were using nebulizers at home, which they can be, to every night take apart their nebulizer equipment and wash it in hot soapy water and then air dry it. In the hospital, you're going to have to get a little bit more creative and make sure that you're keeping it as clean as you can possibly keep it, replacing it as needed, so we're not putting that patient at more risk for infection. So that's it. You guys have the slides. These are meds that you guys should be somewhat familiar with, and if you're not at this point, you will be, because you will see these medications a lot in the hospital. So any questions, let me know. Thanks.